Good afternoon, our dear students. I am glad to see here in a new lecture cycle in Propaedeutics of Internal Medicine. This lecture is from MA groups of third year students. These students previous year had some not a big cycle, not a big part of discipline that named care of patients, and this part named care of patients in internal medicine, and teachers and doctors of our department work with you in this discipline. But this year on third course we are starting a new big disciplines that is very important for your future practice. It has a very unusual name, Propaedeutics of Internal Medicine, and the name of this lecture I name it on YouTube like Introduction, Propaedeutics as an Introduction to Internal Medicine. Another name that we can give to this subject is Introduction to Internal Medicine or Approach to the Patient. And it is a very important moment that we have to stop on before you start to studying general internal medicine by systems, by organs, by several main disciplines in internal medicine. All of them we will discuss with you. Internal medicine, the syndromes and disease you will learn on fourth, fifth, and sixth year of your education. And on third course we have an introduction or approach to the patient, because without this approach, without main moments of diagnosing, physical diagnosing, the rules of conversation to patients, the rules of objective examination of patient, main methods of laboratory studies, instrumental studies, without it will be all internal medicine syndromatic by disease. It's too theoretic for you. Before studying all theories, all moments about each disease, we have to discuss in general how to diagnose a patient, how to work with the patient. And it is one of the most important moments and one of the most important things for your future as a doctor, for your future practice and your success of the doctors, because the approach to the patient and your skills in a working individual work in this patient, working near the hospital bed, it is one of the most important skill in your future practice. That's why here in our study programs, we during all third course, during all study year, you have such an important disciplines that describe you, that help you to learn and help you to practice introduction and approaches to the patient. Unfortunately, you know that this year we have online education in Kharkiv, Kharkiv National University, because Russia-Ukrainian war. And this year, unfortunately, we don't have possibility to give you some practical moments and working with a real patient, but you will have lectures and practical classes during this discipline. That's why on practical classes with the teachers of our department, we prepared to you a lot of different interesting activity, like online master classes, when the teachers will show you some educational videos, when teachers maybe show you something online on some simulators, or even by arms or with another person, but online show you some methodics of objective examination. Teachers will give you practical homework that you can practice with your friends, with your relatives, with your neighbors, and the main result that we have to get from propaedeutics of internal medicine, and it is your skills of examination. And before examination of different pathologies, you have to examine and you have to know how what a normal clinical picture, and that's why it will be very good practice to you to do some skills, to do some procedures, objective manual procedures with your friends and relatives, and maybe teachers online will control this process, will help you with some advices. That's why please don't ignore these practical moments, and don't ignore some homeworks. For example, it is palpation of thyroid glands. During practical class, teachers describe you and help you to learn all technique. Teachers will show you on camera how to do it, maybe to practice with somebody some moment, but at home teachers after it ask you to practice with your family. For example, 2, 3, 5 persons, you have to palpate to remember some moments and to practice this technique. And please don't ignore these home tasks, because it is a very important. All of us hope and we are sure that not in a long period Ukraine will win, and after it all of us return to our lovely Kharkiv, return to our lovely university, and in short time me and all our doctors of our department will glad to see you in hospitals, in our classrooms, in some treatment departments of hospitals, and I'm sure that in short period we will be able to show you real patients with a real disease and real symptomatic, and it really will be interesting for you. But until it's not available option, you have a really huge number of work, huge volume of work with self-education, with working with resources, books, some educational websites, and practicing with each other, with friends, with colleagues, and with relatives. And that's why I hope and I sure that this year will be very interesting, very useful, and become a basis of your future success as a practical doctors. Maybe most of you does not know me. My name is Dr. Maria Brinza. I'm head of Department of Propaedeutics of Internal Medicine and Physical Rehabilitation. At this department, at our department, you will have classes during 2 years. It is third year propaedeutics of internal medicine, and fourth year it is internal first cycles of internal medicine. That's why during these 2 years, I hope we will work in a very, very interesting and very, very useful way. And today is the first lecture for third year students, and this first lecture it not contain a lot of practical information, but it is a very important. In general, I will tell you a lot what is internal medicine. We will give definitions to main terms in internal medicine. I will explain you what is propaedeutics and why propaedeutics, because in Western universities, for example, you will not meet propaedeutics, and we principally leave this word in our educational plan, because we really believe that it is important thing. It is one of the most important things in the future medical practice. We will discuss basic concepts. I will stop a little about medical ethics and deontology in clinic of internal medicine, what is approach to the patients, what is objective examination, interviewing of patient very shortly. In general, I will stop what is it, and very shortly we will name main instrumental and laboratory studies in patient examination. I told you that it just main meaning of this discipline. It is the topic of our today's lecture. That's why for today you cannot conspect some specific terms. I want you just hearing and listening and trying to understand the main philosophy of our subject. And from the next lecture we will start a very practical and very important moments. We have not a lot hours of lecture for this discipline, because that's why every lecture I recommend you listening carefully. Maybe not for you something, because it's not enough time to me even for main things. That's why I include in my lecture main of the main. That's why please, working online according to schedule. I always leave all recordings of streams on my YouTube channel. That's why if you are late on the lecture or don't have possibility to fix something, or during lecture it was not understandable and you have to return to some information, I leave on all recordings to my YouTube channel, and you will have possibility to return to these recordings and return to some part of the lectures. And usually I ask for all students who listening my lectures to leave in comments your name and number of your group for some our individual controlling who listening our lecture. That's why it is all rules and all introduction to introduction what I want to say today. Let's start working with our lecture, and we're starting from definitions. What is internal medicine? Yes, it is the biggest discipline in your studying in general. During third, fourth, fifth and sixth course, a lot of hours, a lot of credits you will have in internal medicine. What is internal medicine? Let's decide. Internal medicine, it is a medical specialty dedicated to the diagnosis and medical treatment of adults. You understand that it is a huge part of medicine in general. A physician who specializes in internal medicine is referred to as internist. Specialties of internal medicine include, yes, we divide internal on several specialties, and all of these specialties have their own specialized doctors. What it can be? They include cardiology, the heart diseases, endocrinology, hormone disorders, hematology, blood disorders, infection diseases, gastroenterology, diseases of gut, nephrology, kidney diseases, oncology, cancer, pulmonology, lung disorders, and rheumatology, that studies arthritis and musculoskeletal disorders. There are two parts of internal medicine. It is infection disease and oncology. You will learn during your studies in separate disciplines in another department. It is specialized department on oncology and specialized department of infection diseases. But all others, it is cardiology, endocrinology, hematology, gastro, nephro, pulmo, and rheumatology. You will learn here in internal medicine, in a big internal medicine cycle. And propaedeutics. What is propaedeutics? It is a historical term for an introductory course in the art of science. I want to stop a little on history. from where it take its beginning internal medicine. The development of internal medicine as scientific discipline begins from such a scientist like Thomas Sydenham. And he studies and he write such thing like concept of disease in general. All general concept, modern concept of disease goes from him in 17th century. Sydenham closely observed clinical phenomena at the patient's bedside and conceived for the first time the possibility of variety of distinct diseases as opposed to the general illness caused by imbalance of humors, which was the prevailing theory of the disease causation before Sydenham. Sydenham's work created a framework of classification of diseases which was built upon the François Bossier de Savage, who in 1763 published the first methodical nosology or description of disease symptoms. One more term for you, nosology. It is a description of some symptoms typical for some disease. Savage emphasized symptomatology as the basis of disease classifications, since there was no information then available about the causes of disease. There was the first Sydenham and de Savage. From the time of Savage until the 20th century, internists could do little to treat diseases. Unlike surgeons who could remove offending organ, internist has no specific therapies. Most of the treatments that physician could offer made patient worse, not better. You can read historical literature. It was absolutely different methods of disease, and all of them was no ineffective. It is different plants, different manipulations, different some strange things they always do with the patient, but most of them, and maybe all of them, was no have any effect. The measure of the internist's skill was the accuracy of his diagnosis and the reliability of his advice about probable outcome of the disease. It's real one thing that doctors, internists could do in those times. They put nearly diagnosis and to make a prognosis. That's all really. Only with the development of disease-specific therapies at the beginning of the 20th century did internal medicine become effective in cure rather than just the supportive care of patients. As more and more specific medications and courses of therapy became available, the volume of medical knowledge increased. More and more subspecialties devoted to particular organ systems split off, leaving internal medicine as the specialty of physicians dealing with all problems of adult patient. Okay, let's stop on basic concept of internal medicine. Let's start from the main. What is the health? We have two opposite terms, health and the disease, that we use in medicine. Health, here be attentive and read it please several times. It is a state of physical, mental and social well-being in which disease and infirmity are absent. One more time, physical, mental and social well-being. Please think about it very carefully because, for example, patient who, for example, cut a little bit his arm, yes, it's not physical, a big trauma, it's not disturb a lot patient, yes, in 5 minutes it's all okay, and we can say that this person is healthy. But, for example, patient with physically know any symptoms, for example, with some chronic disorders in remission, now it is all okay, but for example, psychologically he afraid of new disease very much, or for example, this person have social problems and due to it in a risk of a very high risk of different diseases due to social factors. Is it person health? It is a quite philosophic question, but think about it, because the term of health it is not a very confirmed, and it is a very discussable. That's why I think one more time about this short definition. And opposite, what is disease? Disease, it is a particular abnormal condition that negatively affects the structure or function of all part of an organism, and that is not due to any immediate external injury. Diseases are often known to be a medical condition that are associated with specific symptoms and signs. And we're going to give maybe in next slide a definition of what is symptom, what is sign, and what is different between them. But before it, let's have several more terms. First, diagnostic. Diagnostic, it is the sign of methods by which disease is identified. It is identifying of disease. Diagnostics consist of clinical examination and patient and diagnosis basing. What is diagnosis? Diagnosis, it is a short conclusion of a doctor about the essence of the disease and patient's condition expressed in terms of modern medical science, and resulted from the examination of the patient. And we have three main types of diagnosis. This short conclusion of doctor. Three types. First type, it is preliminary diagnosis. It is based on the patient's present complaints and history of present disease, that we name in Latin anamnesis morbi, the past history of the patient, anamnesis vitae, and physical examination data. It is inspection, palpation, percussion, and auscultation data. What is that? It is one of the most important things in medicine in general. And it is result of your level of your skills as a doctor. It is preliminary diagnosis. One more time, what is that? It is a diagnosis that you have after conversation of patient, analyzing his complaints, anamnesis morbi, anamnesis vitae, and objective examination. It is inspection, it is palpation, percussion, and auscultation of patient. It is everything that you can do as a doctor with your mind and with your professional skills, simply with your arms. Yes, you examine patient, and after it you put a preliminary diagnosis. And very important thing, you must have preliminary diagnosis after physical examination and after examination and conversation with patient, because a real success practice in internal medicine and in medicine in general based on your mind, because for today, as 100 years ago, as now in year 2022, the main instrument and 80% of all diagnostic success, it is the mind of the doctor. No CT scans, no MRI, no laboratory studies, no the most modern test, not take even 20% of diagnosis. And even the best diagnostic studies, the best instrumental and laboratory studies, they must be prescribed just after putting a preliminary diagnosis. What it means, before you prescribe any test, is it simple from the simple complete blood count till the most difficult radionuclide CT scanning must be prescribed just after doctor tell with the patient, examine patient and put a preliminary diagnosis. Just a preliminary diagnosis, at least in the mind of doctor, it is a moment when a doctor can prescribe additional test. One more time, objective, it is a main examination, and all lab and instrumental studies, they are additional. One more time, just after preliminary diagnosis. It can't be that you have any mind what with the doctor. For example, patient come to you and tell, oh doctor, I have a headache. Doctor answer, okay, go to the CT scan and lab analysis, blood, urine and biochemical blood. You can't do it in any countries of the world. It's not connected with the possibility to do modern tests. Even in a best hospitals of the world, all prescriptions, all additional diagnostic tests must be prescribed just after you have some diagnostic idea. We name it preliminary diagnosis. What it means? Patient come to you, told that he has a headache. You do full, you take full complaints, full history, do objective examination. So after it suspect something, for example, you suspect hypertension, according to physical examination and conversation with the patient. And just after you put a preliminary diagnosis, it is arterial hypertension, you have preliminary suspect what stage, what degree, you will learn all of it. Just after it, you can prescribe ultrasound of heart if you needed, CT scan if you needed, blood test and other. That's why putting a preliminary diagnosis, it is main thing in success of diagnostic process and success you as a doctor. After you prescribe additional tests, you get all results from lab tests, from instrumental tests. You confirm or not confirm a preliminary diagnosis. You can change it or you can confirm it completely, or you can just detailize it. You can put diagnosis that we name clinical diagnosis. One more time, definition, it based on subjective examination. It includes complaints, anamnesis, morbi and viter, objective examination, and you add to it instrumental and laboratory studies. On results on it, you can put a clinical diagnosis. And we have one more type of diagnosis, we name it final diagnosis. It's based on the subjective examination and treatment. And diagnosis, all those diagnoses can have a following structure. It consists of main disease. It consists of complication of main disease if they are present, and concomitant disease if they are present. Let's give an example. Okay, return one more time to the arterial hypertension. Main disease here will be arterial hypertension. You have to classify it by severity. Yes, it is a stage, degree of arterial hypertension, and hypertension we usually classify in cardiovascular risk. For example, it is arterial hypertension, second degree, high risk, but this patient during examination you find a hypertrophy of left ventricular of heart. What it means? You suspect a hypertensive heart that is usually result of arterial hypertension. It is its complication. That's why after the main diagnosis, arterial hypertension, second degree, high risk, you write hypertensive heart. And for example, during taking the anamnesis, you know that this patient has chronic gastritis, and during examination you confirm this chronic gastritis, and it's not connected with main disease, it's not connected with hypertension, but it's present in this patient. That's why diagnosis have to include this moment. That's why full diagnosis will have to be written like arterial hypertension, second degree, high cardiovascular risk, hypertensive heart, chronic gastritis. It is complete diagnosis. And each of them, as preliminary, as clinical, as final, can be consist of all these three parts, depending of what volume of information you have in this moment. Okay, what I promised you, symptom and sign. What is symptom? Symptom, it is a sign of disease and pathological changes in the patient's organism. Symptom can be subjective and objective. Subjective symptoms are those that can be found on examination of the patient. Objective symptoms are those that can be found on examination of patient. That, for example, headache, it is always subjective symptom, because a patient can tell about it to you as a doctor, and it is patient's subjective feeling, and you can't check it, and you can't touch it, you can't measure it in any way. That's why it's always subjective. And for example, edema, low extremities edema, like an example, it can be as subjective as objective. For example, if patients tell you that after a hard day in the evening I have edema of low extremities. Yes, it is subjective feeling of the patient. That's why this symptom is subjective. But if during physical examination you check low extremities and find edema, you find it and you feel it, you see it, and you can check its severity, measure its severity, it means that it is objective symptom. Another types of symptoms, I told that it can be objective, subjective. Moreover, it can be pathologic or compensatory. It can be specific or no specific. It can be early or late, and it can be favorable or unfavorable. Please work with it individually. Who can't understand, please write your questions. I will answer. What is syndrome? It is a little bit other word from symptoms. Syndrome is defined as a combination of symptoms that are interrelated and give rise to one another. And what is syndrome complex? It is defined as symptoms that are not interrelated and not give rise to one other. That's why we have symptoms. It is just one sign, for example, red skin. Yeah, a syndrome, it is a complex of symptoms that interrelated to each other Like an example, it is proteinuria, hyperproteinemia, hypercholesterolemia, and edema. It is a complex of symptoms that interrelated to each other, and they are usual for nephrotic syndrome. Yes, it is a syndrome, this complex. And for example, it is headache. It is a problem with the joint, and it is burning feeling in the chest. Yes, it is syndrome complex because we suspect that these symptoms not interfere to each other. Okay, ethics and deontology. It is a very important part. Please read at home more because it is a really important and necessary skill for the doctors. I will stop on it quickly because I don't have time during this lecture. I'm lating a little bit. Let's give a main definitions. Deontology, it is professional ethics of medical workers and principles of behavior of medical personnel directed toward maximum benefit of treatment. Medical ethics, it is a study of moral values and judgments as they apply to medicine. Ethical principles, it is beneficence and non-maleficence, autonomy and consent, truth-telling, confidentially, preservation of life, and justice. Let's stop quickly on each of them because it is a really important things. What is beneficence and maleficence? Beneficence, it is an act of doing good, while non-maleficence, it is act of not doing bad. Think for yourself. How do you suppose what of them are more important? Of course, both of them are important in medicine, but what is more important? It is your question for your homework. In the practical terms, medical practitioners have an ethical responsibility to strive to do that is the best interest of their patients. However, it is important to remember that, that some medical interventions may seem beneficial but may also carry with them the possibility of causing harm. In fact, nearly all medical treatments and procedures, it could be argued, harm the patient in some way. But it is more to do when the magnitude of the benefit versus the magnitude of potential risk. If benefit is higher, we prescribe it. What is autonomy and consent? Autonomy, it is the right of the patient to make an informed, uncoerced decision about their own health management. In this principle is disregarded by a medical professional because he or she believes another decision would be better for the patient. Then it is termed a paternalism. It is a bad thing in medicine. It not have to be. Even as a doctor, you think that it is a better for patient. You can do this decision. You can do this procedure if patient after all information, after all conversation with the doctor, don't want to do it. You can't do it. It is autonomy of patients. The autonomous decision should never be overruled by a medical professional, but not all decisions are autonomous. For patients to have autonomy, they must have a capacity to receive, retain and repeat the information that is given to them, provided the information is complete and given to them in a manner that they can understand. Consent. It is an extension of autonomy and has many types. First type, it is implied consent, when a doctor assumes that certain actions or body language from the patient imply that the patient has consented the planned action of the doctor. For example, it is possible in emergency medicine, for example, the patient well-being, do not let him to conversate to doctor. Patient is nearly unconscious or partially inconscious. It is no relatives here, and doctors have to do something immediately. For example, operation on some diagnostic test, and patient asks for the patient, can I do this emergent operation because I have to save your life for this region because you have this diagnosis. And patient who can't conversate make, for example, like this. In emergency, a doctor can use it like implied consent. Next type, it is expressed oral consent, but when patient has verbally given to the doctor permission to proceed with intended action. It when the patient able to say it. Expressed written consent. It is a documented evidence that the patient has, usually with signature, given consent to a procedure. Written consent should only be obtained after oral consent. And the most useful for us, it is a concept that we always in not emergency medicine have to take from the patient. It is fully informed written consent. It is consent given after being given all the information about the procedure or treatment. When possible, fully informed consent, both written and oral, should be obtained before any procedure, examination, or treatment. The ethical principle of truth-telling is the process in which doctor gives the patient all known information about their health. It allows the patient to be fully informed and therefore allows for the ethical principles of autonomy and consent. A point of note that always needs to be considered is the fact that some patients do not want the information. Therefore, it is important to ask the patient if they want to know or not. The only other extremely rare occasion when it is acceptable not to tell the patient the truth is when the patient may come to harm. When being told, if you tell me I have cancer, I will kill myself. Just in this case, and it is really very rare, when the patient expressed to do harm for him or herself, if you tell the truth. Just in this case, you cannot tell. To all other cases, you must tell truth to the patient. If the relatives come to you and ask, please don't tell my grandma that she has cancer, you can't not tell truth. It is illegal for you as a doctor and not ethical. Next principle. The ethical principle of confidentiality. Ensure that the medical information held about a patient is acceptable only for those to whom the patient has given access via autonomous and full informed consent. You can give this information just for patient or for person who patient gave this right. In order to achieve trust between medical professionals and their patients, confidentiality must be maintained. Even with your colleagues, you cannot discuss medical information individually for those patients. Confidentiality may be broken if information shared by the patient refers to potential danger to public safety or if it is ordered by a court. Yes, here understandable. For example, by order of court, or for example, it is infection. Yes, endemic infection, and you have to tell this information to prevent further diseases. Next principle, it is preservation of life. It is a will to treat the patient illness with aim of prolonging life. After all, most patients want to live longer, and really most doctors may have joined to profession to save lives. This principle may be overruled if the patient has made a living while studying their desire not be resuscitated. You know about these cases. Next, justice. Justice refers to the distribution of things and positions of people within society. In a medical setting, justice involves the allocation of healthcare resources and therapy. This may be an equal distribution of maximization of the total of average welfare across the whole society. And a next thing, approach to the patient and interviewing. Here will be a lot of information about importance of it. I will read and explain you quickly. Who needs more information, please stop on slides and ask your questions individually to me. Okay, interviewing of patient. It's really important to stop on it because it is a very, very important thing. A medical interview. It is a practicing physician's most versatile diagnostic and therapeutic tool. However, interviewing is also one of the most difficult clinical skills to master. The demands made on diagnostic reasoning must be balanced with the interpersonal skills needed to establish rapport with the patient and facilitate communication. Who does not know term rapport, please read it. Interviewing is often considered part of art in contrast to the science of medicine. There are many reasons to dispute this distinction. Perhaps the most compelling is that labeling it an art removes interviewing for a real or critical appraisal and suggests that there is something magical or mysterious about interviewing that can't be described or taught. This chapter will demonstrate the validity of interviewing as a clinical science based on critical observation and analysis of the patient without diminishing its excitement as a clinical activity. It provides a guide of conducting initial interviews and making sense of what happens. It will outline the knowledge, attitudes, and skills that lead to effective interviewing. The discussion will focus on problem-oriented diagnostic interview but has the health promotion interview and interviewers. During the follow-up visit will also be mentioned. Most clinicians rate the patient's medical history as having greater diagnostic value than either the physical examination or result of laboratory investigations. It's what I told you about. The clinical adage that about 2/3 of diagnosis can be made on the basis of the history alone with retained its validity despite of technological advances of the modern hospital. An accurate history also provides focus on the physical examination, making it more productive and time efficient. Clinical hypotheses generated during the interview provide the basis for a cost-effective utilization, and clinical laboratory and other diagnostic modalities. The diagnostic utility of the interviewing is complemented by its therapeutic power, as the medium through which positive relationship is established between a doctor and the patient. The empathic patient-centered interview can bolster a patient's sense of self-esteem and lessen the feelings of helplessness that often accompany an episode of illness. The Therapeutic Alliance forged during the clinical encounter provides the foundation for ongoing patient care and education. Fundamentally, the medical interview is purposeful conversation undertaken with a set of goals and priorities clearly maintained in the physician's mind. Its direction reflects the respective needs of both participants, patient and physician. The patient enters the interview seeking relief from the discomfort and uncertainty of illness, while the physician actively conducts the interview in order to clarify the patient's problems and derive diagnostic and therapeutic plans for the patient's benefit. During the interview, the patient's need to have his or her story heard and suffering understood is balanced by the physician's need to know and understand as much as possible about patients and his or her problems. Medical interviews are of two basic types: the problem-oriented and health promotion interviews. The goals of problem-oriented interview reflect the patient's request for help with specific problems. The health promotion interview establishes a data baseline concerning the patient's current and past health problems, assessed current health risk factors like smoking, diet, alcohol consumption, heritable diseases in the family, and can detect early evidence of disease, like a change in bowel habits, weight loss, chest discomfort, etc., that the patient did not consider severe enough to warrant problem-specific visit to the doctor. In reality, most medical encounters combine both the problem-oriented and health promotion approaches. Issues of health promotion and important of all patients and patients who become a doctors for routine checkup may have hidden concept about specific symptoms. In fact, careful questioning about why and when the patient schedules and routine checkup often uncover significant health concepts. That's why it is always a combination of both of them. Okay, the medical interview provides two categories of information unavailable from any other source: what the patient says about the illness and how is it said. What the patient tells the physician provides the fact content of the medical history. The factual content is what the physician edits and records in the written record of medical history. It should include comprehensive chronological report of the patient illness with enough information, both positive and negative, for accurate and inclusive diagnostic reasoning regarding possible etiologies of the patient's problems. The process of the interview is what actually happens between physician and patient during their encounter. Observation of process, both verbal and non-verbal, provides important information about the patient as a person. Through the patient's behavior during the interview, like in facial expression, posture, gestures, he or she communicates emotional concern, reaction to illness, and style of relating to others. Sudden shifts of topic, avoidance of certain issues, and the flow of spontaneous associations may point to concerns they are not expressed directly, and be attentive to the things please. The physician communication style and behavior during the interview is also a critical element of interviewing process. The distinction between contents and process highlights our dual skills required in the medical interview: analytical and interpersonal. Although these skills can be discussed separately, they must be practiced together. The clarity and validity information gathered during the interview, its content may be critically determined by the quality of the relationship that develops between patient and physical aid process. A candid disclosure of patient concern is most likely to come about the context of non-judgmental interviewing style. A final comment on process and content may be helpful for the beginning student. The content and organization of written medical history is often confused with the process by which the clinician actually collects information during the interview. The written medical history is actually a journalistic endeavor in which the clinician edits and organizes the patient's spontaneous report into a formal, organized presentation. The final product is the medical chart may bear little resemblance of the work to the clinical performance at the bedside. Patients rarely report their symptoms in an organized and logical fashion comparable to the description of the disease in medical text. In fact, a patient complains of illness or sickness rather than studying their problems in terms of pathophysiologic categories of disease. Students who expect their patient to present classical symptom complexes in an organized fashion experience considerable frustration and may become rapidly disillusionized with clinical medicine. They complained that the patient was a poor historian may reflect unrealistic expectation on interviewer's part. In clinical practice, interviewing is a collaborative effort between physician and patient. Such a science like Razor states that a physician, no matter how skilled, cannot simply extract history from his patient. The patient, no matter how articulate, can't give history in final form without help and guidance from the physician. Yes, it is a relation, it is always very and verbal and emotional, psychological interfere with the patient and doctor. To say that we take a history from the patient implies that the story of illness can be extracted from the patient like shaking a coin from the piggy bank. This erroneous conception of medical interview leads to frustrated attempts at shaking out the history as if the patient was willfully keeping this valuable coin hidden. Okay, I will not stop on it. Who need this further slide about therapeutic task and establishment of helping relationship between doctors and others, I really have time on it. Please read it individually. Okay, report I ask you to read at home. Who don't understand, stop this slide, please. Okay, it was conversation. I hope everyone understands that it is a really important part of your doctor skill. One of the most and maybe most important. Next step, nearly the same important, it is physical examination. Physical examination is the process of evaluating objective anatomic findings through the use of observation, palpation, percussion, and auscultation. The information obtained must be thoughtfully integrated with patient's history and pathophysiology. Moreover, it is a unique situation in which both patient and physician understand that the interaction is intended to be diagnostic and therapeutic. The physical examination, thoughtfully performed, should yield 20% of the data necessary for patient diagnosis and management. Aside from the hospital room and a doctor's office, physical examination may occur in a variety of other settings where it is difficult to establish privacy and quiet. The best resource available to the physician to set stage for the physical examination is to communicate respect and genuine interest in patient's welfare. The patient should be addressed politely and asked to perform a required manners of examination, a technique far preferable to imperative language such as "I want you to." Patients should be prepared for unpleasant portions of the examination. Aside from explanation and reassurance, it is not necessary to maintain continuous conversation with the patient during the examination. Avoid embarrassing for the patient. Be certain that dripping material is used approximately, that person areas are not subjected to underexposure. The examination that ends abruptly may diminish the value of doctor-patient relationship. and they may destroy its therapeutic content. The patient may benefit from the brief summary of relevant findings and may require reassurance about what has and has not been found. The materials. The single most useful device for optimal performance of physical examination is an inquisitive and sensitive mind of the doctors. It is everything, really everything that you need for diagnosis. Next most useful, mastery of technologies of observation, palpation, percussion, and auscultation. Less important, it is a tools required for examinations. Here you see a table with them. Please stop on it. It is likely to have this equipment, but it is not obligatory. You can do everything even without them. The examination. As the environment affects the quality of the physical examination, it is wise to arrange for quiet and privacy, darkening the room for parts of the examination and comfort of the patient and examiner. The complete examination should proceed in an orderly fashion with a minimum of required position shifts to the patient. On the other hand, the physician must be able to ascertain the integrity of the various organ systems from regional examinators. For instance, from examination of the head, neck, the physician must identify the vascular, neurologic, lymphatic, skeletal, and integumentary components, and must relate them for their complements in other body regions. It would be tedious, by contrast, to examine the vascular system in its entirety, followed by complete neurologic examination and the other organ system each in turn. When examining an anatomic region, the observer must be alert in the appearance of any abnormality and question at the time of morphologic aspect on the abnormality in its clinical significance. Okay, position of patient and examiner during physical examination. It can be sitting or reclining. It can be standing. It can be reclining on examining table, drapes, knees reflected, slats adducted, feet in straps, and other more rare positions. Many of them you see in this table. The general physical examination can take many forms depending upon circumstances. Most often, the examiner evaluates body regions in general way, looking for abnormalities. Clues derived from the history signal the need for more precise and detailed examination of the given system. The through patient examination often includes the sequence present in table. Okay, and table. What we examined. First of all, it is general examination. The patient checking of patient's comfort, the optimal parameters on environment, if it possible, checking for some vital signs in general inspection. After it, system by system, organ by organ, usually we use from up to down. First, it is examination of head with checking eyes, ears, doing ophthalmoscopy. Yes, it is function of internist. Checking of nose, mouth, face. I not stop on symptoms. You can read it from the slide. Checking of neck. After it, we go lower to anterior torso, posterior torso, completion of sitting position of examination. After it, ask patient to lie in supine. It is checking of thorax, checking of abdomen, proximal lower extremities. After we ask patient to stand up. During standing, it is examination of external genitalia, pelvic and rectal examination. The clinically significant physical examination is a flexible entity that should vary from the needs of the patient. It is near a structure just for your easing, but you can change the scheme of objective examination individually for the patient and their ability. Periodic examination for the health assessment need to be comprehensive, as do most hospital admission examinations. In contrast, it will not be cost-effective to undertake a complete physical examination in most patients presenting with the symptoms of an upper respiratory tract infection or urinary tract infection. Because a large degree of variability in observation of patients, the following recommendations can be made for reporting and interpreting physical findings. First, emphasis should be placed in dichotomous variable, like presence of or absence of rails, rather than graded variables, for example, in intensity of breath sounds. Next, it is physical. Some physical signs, like clubbing fingers, represent a continuum from obviously normal to obviously abnormal. Emphasis should be placed on those findings which represent the extremes rather than the borderline cases. Recognition of those physical findings which have high degree of inter-observer variability is important. Good examples of this include detection of moderation of small amounts of ascites fluid and detection of diaphragmatic movements by percussion. These findings should be de-emphasized in favor of those with a better reproducibility. And fourth one, it is beneficial to use the body's symmetry to advantage. Different auscultated and breath sounds between the similar area of right and left lung are far more clinically important than overall decrease in breath sounds. That's why during auscultation we hear not, for example, just all regions of right lung, after it all regions of left lung. We compare upper part of left, upper part of right, lower part of left, lower part of right, and it more clinically informative for you. Okay, and very quickly, instrumental and laboratory methods. We name just general scheme, main of them, because all of them we will learn on different syndromes and diseases and different system disorders. Laboratory tests include range of blood and urine tests. Blood work may include testing for genetics, for inherited disorders, or determine the amount of oxygen in the blood. Urine test may be performed to check blood chemicals, bacteria, and cells for infection and other abnormalities. Types: what I told you is urine test, blood test, and tumor markers. It is main of them. Urine. Urine analysis is laboratory examination of urine for various cells and chemicals, such as red blood cells, white blood cells, infections, or excessive protein. Urine analysis breaks down the components of urine to check the presence of drugs, blood, protein, and other substances. Blood in the urine or hematuria may be result of benign or non-cancerous conditions, but it also can indicate an infection or other problem. High level of protein in urine, like proteinuria, may indicate a kidney or cardiovascular problem. All these symptoms we will learn on those lectures. Blood tests. They are often used to check cell counts, measure various blood chemistries and markers of inflammation, and genetics. Main types of blood tests, just main, not all, because it is a huge number really of different signs that we can check in blood. Main of them: antinuclear antibody, blood chemistry study, blood lipid profile, BNP testing or brain natriuretic peptide testing, complement, complete blood count, creatinine, C-reactive protein, erythrocyte sedimentation rate, fecal occult blood test, genetic studies, hematocrit, liver function test, peripheral blood smear, rheumatoid factors, sedimentation rate, and etc., etc., etc. Tumor markers are substances either released by cancer cells into the blood or urine, or substances created by the body in responses to cancer cells. Tumor markers are substances either released by cancer cells into the blood or urine, or other substances. Tumor markers are used to evaluate how well the patient has responded to treatment and to check for tumor recurrence. Research is currently being conducted of the role of tumor markers in detection, diagnosis, and treatment of cancers. According to National Cancer Institute, tumor markers are useful in identifying potential problem, but they must be used with other tests for the following reasons. What reasons? People with benign condition may also have elevated levels of substances in blood. Not every person with a tumor has tumor markers, and some tumor markers are not specific for any one type of tumor. That's why tumor markers in blood we always confirm with other tests. Instrumental methods. Instrumental methods of diagnostic are widely used for more accurately determine pathological changes in the body and conduct an early diagnosis. This allows timely and maximum effective therapy and predict the course of the disease. The main methods, not all two, but the main of them: instrumental, endoscopy, biopsy, and cytological analysis; functional methods, electrocardiography, spirography, pneumotachography; rentgenologic methods that include rentgenoscopy, X-ray, or rentgenography or X-ray study. It can include tomography and ultrasonic methods. And a question for your self-controlling it for your homework. I will not ask you answers next lecture, just for your individual work and for it just for your self-controlling how you understand this lecture. That's why in your mind or in your conspect please answer on several questions. First, what's the difference between symptom and syndrome? What is the meaning of disease? What examination methods and their diagnostic value? Please give definition. What is diagnosis, its structure and types? And what is the diagnostic value of interviewing of the patient? It's all questions that I want to ask for you. If you have questions or if you have comments or complaints or you want to discuss with me or with other teachers something, we always waiting for your feedback. You can write your questions and comments in comments under this YouTube video, or better I will wait for your questions in our closed Facebook page. It's page Department of Propaedeutics of Internal Medicine and Physical Rehabilitation, and there we always wait for your activity, for your questions, and I will be glad to help you with some maybe difficult or non-understandable moments. That's why always write some feedback, better to write some feedback, or if you have questions or if some moments of the lecture is not very understandable for you, I'm waiting for you in comments or in discussion on Facebook page. And for today that's all. Thank you for your attention. I remind you that everyone who listening my lecture, I ask to write your name and number of your group in comments under the video. Next lecture will be in 2 weeks. and I told that if today it is a more general lecture, from the next lecture we start working with more practical and more important information in propaedeutics of internal medicine. And for today, that's all. Goodbye you, and see you into